Carol, a fixture at my high school in college was torn ACLs. Volleyball, lacrosse, soccer, field hockey. A torn ACL, surgery to reconstruct it, then weeks on crutches, months of recovery, and oftentimes it was girls, not boys, who tore their ACLs.
Which I find interesting. I guess I would have thought it was the other way around.
Girls and women tear their ACLs at a higher rate than men and boys. This is Dr. Martha Murray's world. She's Orthopedic Surgeon-in-Chief for Boston Children's Hospital. She joins us here in Boston, where we are at Boston Children's Hospital. Dr. Murray, welcome. How are you?
I'm good. Thank you so much for having me.
Nice to have you.
So you've got this background in material science and engineering. It's not typical for a surgeon. We're going to talk about your innovation in ACL surgery in just a minute. But on the boys versus girls, men versus women, why do ACL tears affect women more than men?
Well, it's a really interesting question, and it's been one of much debate for the last few decades. And there have been things like, well, it must be a hormone cycle, or it's the shape of women's hips and their valgus angles to their knees. But a really interesting study came out very recently from the Harvard School of Public Health as well as Harvard University with Dr. Danielson and Dr. Richardson, where they actually showed that the studies that say that women tear their ACL more frequently than men were often based when the women's teams were smaller than the men's teams. And the way they calculated exposures was the number of practices or games you played in, not necessarily your playing time. So if you're a man who's on a hockey team versus a woman who's on a hockey team, the women's teams were smaller, so those women were playing more, so they were planting, and hockey is a bad example, soccer would be better, but if the team is smaller, the women are going to be planting and pivoting and playing much more time per game or practice.
So more stress, more use.
More stress, more use, more tears.
So maybe it's not, maybe women and all things equal, maybe women and men don't have a different rate of torn ACLs.
Correct. When they corrected for a unit of exposure, so kind of game time playing rather than just a game, the injury rates look very similar.
Wow, that's totally different than what. I mean, that's.
Yeah.
I mean, is this the standard now? I mean, do you think this is?
It's relatively new work that's coming out, but it resonates with most of us who take care of women and men on their athletic teams. Yeah.
I want to ask about your background, material science and engineering. I know Tim said not typical for a surgeon, but I think it's a really smart combination. Well, I have a doctor, a foot doctor, same thing, engineering, and like he doesn't just deal with my foot. He thinks about, okay, what are you doing? What else is going on in your body? Tell me about that mix and why it's kind of unique and smart and ties things together.
Well, for me, it was actually of necessity, right? So I was an engineering graduate student, and a friend of mine came into a party one night and had, on crutches, as Tim was saying, and had torn his ACL. And I said, "Oh, are they going to go sew it back together?" And he was a med student. He was like, "You stupid engineer! We can't sew it back together. You have to take it out and replace it with a grafted tendon that they're going to take from the back of my leg, and then it's all this rehab." And I thought, that seems kind of excessive, right? Like, that's a lot to have to go through. And so I spent the next 6 months or so in the medical school library just reading everything I could about why didn't the ACL heal. And I realized nobody really had figured out why it didn't heal. They tried it, sewing back together, didn't work, so then went to grafts. And we've been doing grafts for 50 years, and nobody really asked why doesn't it heal. And so for me, then, there was no biomedical engineering at that time. And so my choices were to continue on with my project, which was developing airplane wings that were invisible to, to radar. And I thought, well, that's a really cool project, but I really want to figure out this ACL thing. And my advisor was like, well, I guess you could go to medical school. So,
this is a Netflix series in the making.
Okay, well, the advisor obviously had an impact, and your friend obviously had an impact. But fast forward, 30 years plus, and you have actually invented a new way to treat ACL tears, the Bear method. You did figure out that there's a reason why ACLs don't heal like an MCL would actually heal. Why is that?
Well, it's really interesting. So both the medial collateral ligament and the anterior cruciate ligament are ligaments. When you look at them under the microscope, they look very similar. But interestingly, when the MCL tears, you can go in a brace, and in about 6 weeks, that ligament will heal fine and you're back playing soccer. In contrast, the ACL, when it tears, even if we try to sew it back together, it doesn't heal. And so we wondered why. And so we did a series of studies where we looked and we compared the two tissues and their response to injury. And what we found was that actually the response to injury was very similar in the two ligaments. So the tissue and the cells in the tissue were doing exactly what they were supposed to do in both tissues. But the difference was in the MCL, when it tears, the ends bleed, and that blood clots and forms what we call a hematoma between the two torn ends of the ligament. And then, in contrast, in the ACL, because it lives in this fluid environment of the joint, the ends bleed, but instead of making a clot or a hematoma between the torn ends of the ligament, the blood disperses through the fluid of the joint. And so the two ends never have that scaffolding, that biologic scaffolding to hold them back together. So once we discovered that, then it was a fairly logical step to say, is there some way we could immobilize the blood in between those two torn ligament ends and get that biologic signal where it needs to be to encourage healing of the ACL? And that's really what bridge-enhanced ACL repair, or BARE, is. So the magic is kind of this sponge that we've developed that can absorb the patient's blood. You can place that blood-laden sponge in between the torn ends of the ACL, sew the ACL back together, but now you have the biology plus the sutures and the repair, and the ligament will heal.
So what is done in terms of numbers or percentage with the method that you pioneered, what you invented, versus actual reconstruction and using other ligaments?
That's a great question. So this is still fairly new. So we got FDA approval for this product in 2020, and so it's only been in practice for a few years now. There's studies coming out of Children's here, which is where we did the first studies, of course, but now other centers are coming along and doing follow-on studies, and those results are starting to come out, and it's very exciting to watch it grow.
I'm also curious, you mentioned like FDA approval, like the approval process. Is it a smart one? Is it the right one in terms of making sure that what's being done and studied, the R&D, that it's safe for when it's finally done on patients? Or is it preventing things from maybe put into use sooner? Like, I'm just curious where you guys weigh in. You're in it every day.
Yeah, I think it's a delicate balance, but I would say in our personal experience, the FDA was an amazing partner.
Okay.
So we were able to get into an early adoption program where they actually met with us and helped us and put together a panel of experts that would help us figure out how to make this the safest possible product and the most effective product before we went to patients. And we found their advice incredibly valuable. There was a lot of conversation and back and forth, and just having them, it felt like it was a team effort because we were in alignment. I mean, as a physician, I was going to be shaking the hands of these patients, and my partners were, and we wanted to make sure things were as safe as possible, so they helped us with that.
Do we have data yet on long-term impact or long-term outcomes yet when it comes to the BARE procedure?
Yeah, our longest data that we have is at about 6 years, and it's only in the small number of patients in those first studies that we did. But the reason that we want to study it longer term is because, as you may know, many of these patients will develop arthritis early in life, and as a pediatric orthopedic surgeon, I want to make sure we have a procedure that's going to last my patients for 60 or 70 years, not have the knee break down in 10 or 20 years. And so we're very interested in this arthritis question with BARE, and in our preclinical studies we were able to see that arthritis was actually much less in the subjects that we treated with an ACL repair with the sponge versus a reconstruction. So we're interested in seeing if that same thing plays out in patients, and the early data suggests that it is true, but again, that's very early data on small numbers of patients, so we're excited to see how that pans out.
We're talking with Dr. Martha Murray. She's Orthopedic Surgeon-in-Chief for Boston Children's Hospital. That's where we are, Tim and me, on this Friday. Preventive care. Like, so much of what we talk about often when we're doing interviews is preventive care, and I feel like the whole health community has been thinking about this for a long time. So what's the preventive care so that, as much as we don't want you unemployed, like, how do we think about taking better care if we're living longer? Like, how do we think about this?
So there's a couple questions on that. So one is, how do we help our teenagers reduce their risk of injury? And I think the main thing for that, for our athletes when they're in it,
because we push kids when they're younger. I think a lot of parents really push kids.
So some things we can do to help them is help them work on strengthening in addition to just playtime. And another thing is cross-training. So not playing the same sport all year round or playing the same sport every day, giving their body a chance to rest and heal between exposures to sport.
It's as simple as that.
I think so.
Wow.
Does ACL tear happen more in kids than adults, and if yes, is it because kids are the ones who are playing sports and we're just sitting at computers?
I think that's probably part of it. Again, it gets to this exposure question.
Yeah.
Like, how many times do you plant and change direction? And so the peak of ACL injuries is really the high school athlete, because there's so many. Everybody's playing a sport, and so we see a lot of them there.
I want to ask you about social media and all of us sitting on phones or sitting in front of screens. Like, I keep thinking that we're going to one day, I don't know whether it's 50 years from now, we're going to have a neck that basically goes over there, or maybe not, because we're going to have glasses on, and that's how. Like, how do you think about this digital world? You're laughing, but
can you surgically remove my phone from my hand? That's what Carol wants.
But I
to know.
do think about what it's doing to us.
I
not just
got
our
the
minds,
ACL
but
fixed for you. I don't know if I can fix the social media problem.
But physically, like, I'm just thinking, like, how kids are in their phones constantly and stuff, and like the shape. Do we need to be thinking about what this is doing, kind of to our spine and different things?
I think so, but I also think things come in cycles, right? And we see now, if you walk down the street, you see everybody's on their phone. I think 5 years from now, we're going to look back at that and say, why were we doing that? You know, maybe we'll start looking up at the sky more often.
I hope so.
Yeah, that's what I hope too.
Yeah, I mean, gosh, that's like you're opening up.
I know. I look around on the subway and just everybody, and I'm just thinking the curvature and I don't know, whatever. What's the next thing you're working on or that you're excited about?
I'm really excited about a product that we're working on for rotator cuff injuries. And it's a product that's injectable so that potentially...
That's great.
Yeah, you can have ultrasound of your shoulder, see where the tear is, and then inject the product into the tear maybe in an office visit. So that's what we're working on, but very early days on that.
Again, a challenge with pediatric patients as well?
No, this is more adults, but we thought if we could make this work for a ligament, maybe we could try it for the rotator cuff tendon. And the nice thing about the rotator cuff is it is accessible by ultrasound and injection, and it's a pretty easy model for us to study. If we can make that injectable work there, then there's lots of other places we could apply it, meniscus, other things.
Did you ever figure out the invisible airplane wings?
No.